Greetings, my name is Owen Nkoka. I'm an early career epidemiologist and I work with the Malawi Epidemiology and Intervention Research Unit. Today I've got my colleagues, Michael Udedi, who is the mental health lead at the Ministry of Health of Malawi. I've got Baltazar Mtenga, who is the data scientist and our programmer at Malawi Epidemiology and Intervention Research Unit. And we've got also Memory Bismarck, who is a lived experience expert that is part of the team. We also have other team members that I'll be introducing them during the course of the presentation. Our work today will be presenting our proposal on leveraging existing datasets to understand mental health disorders in rural and urban Malawi. So in terms of the global burden of mental health disorders, it is evident that depressive and anxiety disorders are common across all age groups, particularly starting from ages 5 to 9 and going upwards. And these are estimates that have been developed to show the burden of these common mental health disorders. But since these are just estimates, we do not have data specifically from low and middle income countries to understand what is the real burden of these conditions. So it's important that this data is collected from low and middle income countries like Malawi to understand the actual burden of these common mental health disorders. In Malawi, we have a Healthy Lives Malawi cohort that is funded by WellCome and also Medical Research Council. In the Healthy Lives Malawi cohort, we have the health and demographic surveillance system. We also have nested studies like the long-term conditions survey. We have the birth cohort. We have socioeconomic survey. And we have also established a mental health and NCD clinic. In this, we are collecting a variety of mental health conditions, particularly depression and anxiety. And from these surveys, we refer people to the mental health clinics for further assessment. So we want to improve accessibility of the data that we are collecting, as well as its usage. So from the long-term conditions survey, which is part of the Healthy Lives Malawi cohort, we, at the moment, from data from 28,037 people, we have collected data on depression and anxiety using the patient health questionnaire 9-item and the 7-item general anxiety disorders scale, using a cutoff of 8 and 6 respectively, using the data that validation studies that we have conducted in Malawi. So on this, we see that men from rural areas in dark blue and men from urban areas in light blue, and dark red is women in rural areas and light red is women in urban areas. We see that from adolescence, we have these conditions of depression and anxiety, but they peak from 30 to 49 years of age. So this is a problem. We think that in our surveys, we have actually shown that we do have a burden of depression and anxiety, and we need to further understand this problem in our population. So what are our objectives of this proposed work? We have 6 objectives, 5 of which fall under the data-driven insights theme of this core, and then we have one that is under the digital theme. So we want first to integrate all the data that we have for mental health and longitudinal data from Meru and clinic records, and then answer some research questions on what are the risk factors of or socio-demographic and health related risk factors for depression and anxiety, to look at pregnant women and non-pregnant women and whether they have different risk factors for depression and anxiety, and also to examine barriers and enablers for mental health referral uptake and retention in care, and also to link between the association between depression and anxiety as well as mortality. For digital 2, we want to develop a Meru viewer, which will be an open access digital tool to expand access to mental health data in Malawi, particularly from the Health Lives Malawi cohort. So what is the work that has already been funded? We have the Healthy Lives Malawi, the Generation Malawi projects, which were funded in 2019, and the work has been ongoing until recently. We also have the Depression Genetics in Africa, which is looking at genetics of depression in Africa, and it takes samples from the cohorts that we have developed in Malawi. We also have the genetics of anxiety in Africa. These studies are funded by Wellcome as well as MRC. From these platforms that we have actually generated from the Health Lives Malawi cohort as well as the Generation Malawi, there's the genetics work that has been funded. For the proposal that we are proposing today, we want to look at detailed epidemiological work on the mental health conditions to answer some key research questions in our settings and also to improve data accessibility. So that's what we are doing to avoid duplication of the work or funding efforts. So in terms of our methods, we have 3 work streams that we are going to look at. Work package number 1 will involve linkage of all the data sets that we have from the Health Lives Malawi cohort, particularly linking clinic records to survey data from the birth cohort, health and demographic surveillance, long-term conditions survey data, as well as socioeconomic data, to create a harmonized database for mental health conditions in our setting. And this will lead to the harmonized database for work package number 2, that will help us to come up with policy briefs, result briefs, as well as journal papers as our outputs. For work package number 3, we are going to look at or develop a tool that will help to put our data out there for stakeholders, researchers, people with lived experience, and anyone interested in mental health to access the data that is being collected and to look at the summaries that we have. So we'll create a dashboard for mental health. So our work is split into 2 themes for this mental health data prize core: the data-driven insights, which has work package 1 for data linkage, and our data at Meru. All individuals taking part in the surveys have a unique identity or ID, which we call ident, and this will be linked. All the surveys that an individual has taken part of, if they have gone to the mental health clinic, if they are in the birth cohort, if they're in the long-term conditions, we are all going to link all that using the ident. And studies also have different study IDs, which we are going to identify using the study IDs. For data analysis, because we have the longitudinal data from the health and demographic surveillance, we are able to look at the risk of death using the Cox proportional hazard models, multi-level regression models, as well as multivariable regression models, to understand some of the key questions that we want to answer using the dataset that we have. And for tool development, we are going to use a human-centered design, where we'll get feedback from different stakeholders, including people with lived experience. And we're also going to use artificial intelligence and machine learning techniques to create predictive models to identify people at risk of common mental health disorders. And this will be portrayed in our database or in our dashboard. So how are we going to use the machine learning techniques? So we have the harmonized database that we have created using the linkage that I've actually talked of. From this, using supervised machine learning techniques and also unsupervised machine learning techniques, we are going to create predictive models for the variables that are of interest, having gotten feedback from different stakeholders, to stratify risk from high, medium, and low. And this will be shown in terms of the dashboard that we are going to create. And we are going to draw insights using SHARP technique as well as LIME technique in the Meru viewer. So regarding ethics, our surveys, the Health Lives Malawi cohort, including all the nested surveys, the birth cohort, the long-term condition survey, has been approved by the National Health Sciences Research Committee, and all survey participants have also consented to taking part and also for their data to be used for scientific purposes, for research purposes. They have also consented. So when we look at the data that we have at the moment, 99% have consented for their data to be shared with other researchers to answer some key research questions. So we have data that can be used and shared among researchers. We are a team of people that have engaged with different stakeholders. This is a team from Malawi Epidemiology and Intervention Research Unit, but in our team we have also individuals from Kamuzu University of Health Sciences, the Ministry of Health. At MER, we have developed what we call community advisory groups. These are community members, representatives that also have a voice in the research that we conduct. And we're also working with the Mental Health Users and Carers Association of Malawi, where we are getting the people with lived experiences. And we also have support from advisors from the University of Glasgow, London School of Hygiene and Tropical Medicine, as well as University of Edinburgh. So the question would be, how are we going to involve people with lived experiences? So in our team, we have a co-investigator who is a lived experience expert and has been part of the research question formulation and the design of this proposal. And once we start analyzing our data, we are going to constantly engage the people with lived experiences in terms of the data interpretation to understand the perspective of people with lived experiences. And for dissemination of our results, we are going to consistently work with people with lived experiences to be part of the authors for the policy briefs, result briefs, as well as the manuscripts that are going to be generated from this work. And we are also going to engage the Ministry of Health together with people with lived experience to ensure that the advocacy that they want to bring is well informed. And for the digital tool, since it's human-centered design, we are going to provide, or we're going to get feedback from people with lived experiences to ensure that this is user-friendly and it makes sense to them. And by involving people with lived experience in the project, we believe that we are going to build the capacity through leadership of projects like this one. So, how do we plan on scalability, or what is the potential for scalability of this proposal? We think that the unified database that we are creating can be expanded to include other mental health data sets along the way and other longitudinal data sets to be able to portray or to see how we can integrate them into one unified database. And for the open access tool, we believe that this is a replicable model that can be used at a national level. If it's successful, then maybe the Ministry of Health can adopt that to consolidate all the mental health data within the country to be able to see the status of mental health in the country. In terms of the digital platform accessibility, we feel that since it's open access, it can be used by different stakeholders, researchers, clinicians for broader applications. And the questions that we are going to answer using the data that we have consolidated and the analysis that is going to be made, we think that it might have policy implications to design interventions that are context specific for Malawi and also for the region. How do we see our proposal and its impact? So for work package number 1, we feel that the data linkages will help in understanding different mental health outcomes because we have the clinic data that is being linked with the survey data, and therefore we can answer some key research questions in the end that would help us to come up with or to bring interventions that are relevant to improve mental health outcomes in our setting. For work package number 2, where we're doing the analysis, we believe that this will help in evidence-based decision making, but also with our constant engagement of people with lived experience, we think this will be an advocacy tool for people with lived experiences to push on their agenda in terms of mental health. And then lastly, for the digital tool, we believe that this will improve on data access, which is already limited in our setting. So overall, we believe that this project, also having a lot of early career researchers, it's going to build capacity of these early career researchers in implementing in projects of this scale. So I'll briefly show you our team. Our team comprises of early career researchers, epidemiologists, and as clinical researchers. We have mental health experts from Kamuzu University of Health Sciences. We have people from with social science and community engagement and involvement background. We have data scientists. We have mental health policy maker, as well as a lived experience expert. So with the composition of this team, we believe that mentorship will be part of the project, where the early career researchers will be led and mentored by people that have experience in research project leadership, particularly in mental health research. And also, we are going to have workshops with different stakeholders on how they can actually use the Meru viewer that we are going to be developing. So that will build their capacity on the usage of the viewer. We are planning to constantly engage our stakeholders in every quarter to update them on the progress of the project, as well as engagement with the policymakers throughout the course of implementing the project. And luckily enough, we have a mental health lead within the Ministry of Health that will provide that link between the project and the ministry. And we are going to have social media engagement using our social media handles on Twitter and other platforms, and as well as we are going to conduct media engagement activities to ensure that the public is aware of our project. And we are going to do community engagements. This is also a policy within Meru that all the projects, we have an interface with communities through the community advisory groups, as well as the leadership of the community, for them to understand. We are going to produce result briefs, manuscripts, as well as we are going to attend conferences and produce policy briefs as part of our dissemination plan. So in the short term, we want to make sense of the data that is being collected on mental health within our platforms, and to understand what are the barriers and enablers of mental health service uptake, because we have the mental health clinics in the rural and urban site, and to create a unified database for mental health research, which will allow in the longer term to have other mental health data incorporated, and also to understand the impact of mental health on mortality. So in the medium term, we think that we are going to address barriers to service uptake, mental health service uptake, by improving access to mental health services, as well as addressing those barriers. We also want to improve access to mental health data metrics in Malawi through the Meru viewer. And by engaging people with lived experiences, we want to improve their voices in mental health research in this setting. So over time, we believe that we are going to provide a replicable model for mental health data integration in similar settings, build capacity of mental health researchers, because we have a lot of early career researchers in this project, and then also to develop context-specific interventions designed because of the increased understanding of mental health in these settings. So overall, we are using data from the Healthy Lives Malawi cohort, the birth cohort, mental health clinic data, demographic surveillance, as well as longitudinal data. All this data have elements of mental health, and want to integrate them into a unified database to draw data-driven insights in the medium term, as well as to create a digital viewer to improve accessibility of this data to different stakeholders. And lastly, we think in the long term, this will have policy implications, as well as it will help us to develop interventions that are context specific to address mental health in Malawi. Thank you very much.